which is just a compliance check and a leak test on the ventilator. Make sure that nothing like that is going to harm our baby with that. Our main power switch is here in the back. It's just underneath a little swinging tab, and it has an on-off switch right here. You just put it on and the vent will immediately start alarming. When we set this up, we always go for a new patient. And then we hit patient accept. It automatically goes to neonatal because it just analyzes the side, and these have been used in the neonatal section. Next, when we do, I always put my AAC on. That is our tube compensation. So it overcomes the size of the tube and the resistance to get the air into that. Next, I always put my leak comp on because here we don't use cuffed tubes. We use all uncuffed tubes, and it helps with giving more flow to the baby to hit those set volumes. We place our tube size in. We have all the way up to adult sizes, but we primarily here have 2.5s all the way up to 3.5s to 4s. We base this off of, most of the time, our NNPs, less than 1,000 grams are typically our 2.5 tubes, 2,000s are about our 3s, above that are our 3.5s, our big kid tubes. And we also put in where we cut our tube to, what length it's at. We have all of our suctions are either 6 Frenches or 8 Frenches, and we cut them and stick them on this side. So it is important for us to know where it's cut, not only for suctioning, but for our vent settings also. We type in our patient's weight. Also, it helps that we could see it every day. When they get weighed, you can put it into here, and it also does a little bit more calculations on the ventilator itself. And when you're setting those volume guarantees, you can do, it calculates most of the numbers for you. Most of the time it's pretty easy math though. So we'll say that our baby is 2 kilos just for easy math. And then even from this screen, you can select what mode you're going to place your baby in. This ventilator goes primarily into TCPL mode. It's time constant pressure limited mode. There are different modes at each facility, but for you guys, it's going to be TCPL. They are actually working on it to get it into Epic, but for right now, the orders come across from the NPs called ACVC Plus. With that, they have the set tidal volume, set rate, set PIP, and then set volume, rate, PIP, PEEP. So with TCP AC, you can set this on a baby, and what it will do is you'll give you a set rate right here, then your set inspiratory pressure. We set the peak flow and the inspiratory time. You guys really shouldn't have to move any of that. They're very specific settings. We set the PEEP and the FiO2 right here. So that's just on your PCAC mode, is straight pressure control. The Neo here have been primarily wanting us to use volume guarantee mode. With the volume guarantee, you immediately see one number change on this bottom of the screen that's set. And that is, it's trying to give a set volume now. It is still in that pressure limited mode, but it's trying to target a volume. So you can change that. Your volume that you are giving, we always start at about 6 milligrams per kilo. So for our 2 kilo baby, our tidal volume would be 12 that we are trying to target. And you're saying, okay, so we're setting 12 now, but we're in a pressure mode. How we see that is we go into advanced settings. Anything with these little tiny yellow tick marks, it means that there is an advanced setting available for that mode. When you hit that volume, you see your pressure limit is still right there given to your baby. So the baby is still going to be getting that pressure limit. You're just trying to get a volume every time instead of a pressure. With the pressure only, you don't have a set volume. It can be whatever the baby wants to breathe. When you add that volume guarantee, it guarantees that baby's getting really close to that volume, but limited by that pressure. It can't go above that pressure to get to said volume. The next one is TCPL SIMV. This is the mode that they're kind of using for weaning because it allows you to give these pressure support ventilations. Those pressure support ventilations allow the baby to breathe on their own and get what they want to take. So in TCPL AC, every single breath is given to them at that volume and that pressure that you set. Doesn't matter if the baby triggers it, you trigger it, or the vent triggers it. With SIMV, whenever those babies trigger their own breath, it gives them less pressure, and it's kind of seen that they are doing the work themselves. So that's a really good indicator for when you guys are weaning, getting ready to extubate, everything like that. With SIMV, you can just do it normal, and that's just truly pressure SIMV. TCPL and pressure SIMV are very closely the same mode. The only difference is the inspiratory time that it takes. However, that is set the same for both of our modes, how we use it in the NICU world, so it doesn't really matter. When we can do TCPL with also a volume guarantee, it is like weaning on the vent, except they can get a more set volume with all of the mandatory breaths that the vent gives them, set by the respiratory rate. With that, same thing. As soon as you set the volume guarantee, your inspiratory pressure changes back to a volume every time you hit your volume guarantee. We turn that back up to 12 just for 6 mils per kilo, and make sure that in our advanced settings that is still at the PIP that the neonatologist has ordered. With that, you guys, I kind of wrote it up on the board. They put in the orders for it, and the main one, you guys are usually really great about it, is how they write their PIP orders. They do the PIP orders is their pressure control, what is set, plus their PEEP. So if they write a pressure that says 20 and a PEEP of 5, you guys are going to set your inspiratory pressure for 15 and then your PEEP for 5. So you just have to do a little bit of addition. Where it does get a little funky sometimes is when you are weaning those settings and you're on a 20/5, and then all of a sudden they're like, oh hey, they're looking really good, can we go down to, we'll just even say 18/5, but they didn't change one of the orders. So you just have to make sure that both your pressure, inspiratory pressure, and your PEEP, you're like, okay, so do you guys actually want what pressure you're going to set versus your PEEP? I see it more when it goes off, when you're changing your PEEP versus your pressure. So if it's 20/6 all of a sudden, do you still want that same inspiratory pressure of 15? Or do you want 14/6 or 15/6? Because that does change it either to 20 or 21. So just kind of make sure that your math always lines up for what you guys are increasing PEEP, decreasing PEEP, PIP, everything like that. We set the alarm limits ourselves. The RTs, they're pretty standard for most of it. Our alarms can actually be a little bit wider with the NEOs just because it allows them to breathe over the vent itself, and just as long as it's not hurting the baby. So we always set a high respiratory rate, that way it alarms with us when they are trying to go breathe super fast. You can catch it a lot quicker. And I always set my high tidal volume rate to be only 10 mils per kilo above what they are breathing. That way they can't get atelect trauma, they can't get barotrauma, their lungs aren't going to pop, they're not going to get pneumos. The Avea vent also drops pressure at whatever your high pressure is set. There are some vents, the G5s, if you guys work at Littleton and other places, you set your peak at 40 and it alarms at 30. These vents alarm at 30, drop pressure at 30. Our apnea second, I always keep at 20 seconds. That is going to be most important when you're in those SIMV modes, because you don't want your baby to go without breath when they're doing their spontaneous breathing, getting ready for extubation. So how we look at this bottom row is always going to be what is set and what the baby should be getting. I believe you guys still do the Q1 hour oxygen checks, everything like that in the NICU. I don't believe that'll change if the baby's on the vent. And so you guys will be able to see the rate, the volume or the PIP, the PEEP, the pressure support, and the FiO2. I believe on your guys' charting you guys also see the inspiratory time. But everything else I don't believe is on your charting. The flow rate, the bias flow, the flow trigger, those are all pretty much set on here. There's specific settings that are for neonates and the RT charting. Then you get to this column on this side right here. This is what the baby is actually breathing. So we do want to know their actual respiratory rate, their peak pressures that are inside of their lungs, their tidal volume that they're getting. We want to make sure it's close to that 6 mils per kilo as possible. And then their minute ventilation, which is that respiratory rate times tidal volume. Really good measurement to see what their CO2 waste is, see how much they are ventilating. And then I moved all of the vents now to put the mean airway pressure on there. So that is the map. If you guys have ever worked with the oscillators, it's the best indication of total oxygenation within the lungs. So I moved all of those to same mean. We typically want their mean around less than 10 if we are starting to do extubation, weaning, anything like that. What's it gonna do next? Oh yeah, that's right. The next one is your suction button. So you guys have watched me hit this alarm silence. It silences it for 2 minutes straight whenever you hit the alarm silence. However, when you guys hit the suction button, you do the oxygen increase and the alarm silence concurrently. On the neonatal mode, it also increases the bias flow and reduces the loss of peak when you guys hit the suction button. So every time you do suction, instead of just hitting these two concurrently, the suction button actually does help the baby get a little bit more flow and doesn't collapse their lungs as much. So hit the suction button. With that, these vents are actually set up to go up 20% when you hit this FiO2 button. It only goes up for 2 minutes. When we do hit that O2 increase button, we all know increased O2, oxygen toxicity, ROP, increased antioxidants, everything like that. So if they are needing to keep hitting this button, we should probably just go up on the FiO2 or kind of see what's going wrong with our baby. With itty bitties, we can change that to only go up by 10%. It's in the screens, utility, and then you can change it just to go up by 10%. And just hit main. This vent does not ever stop alarming and it never turns off. So if you are just sitting here waiting for the baby to be tubed, waiting for them to be intubated, it does not stop. There's no official standby mode on this. You can put it into standby by hitting screens and then standby and then hitting yes. However, when you are in that mode, you cannot change anything. It is locked. Most other vents, you are allowed to change things while it's in standby. This one, you cannot. So whenever you guys are getting ready, they're surfing a baby, you're bagging the baby, anything, and you need to put it into standby, just know you cannot make any changes to the ventilator if they're telling you without turning it back on and then silencing it. Like, even when you turn the vent on, it alarms no matter what. So it's one of those key things about this vent. I know it's a lot. What questions do you guys have? We set the inspiratory time. Usually itty bits get like 0.3 eye time. These vents, I'd say we go about 0.35. It's just the most common eye time for babies. Those chronic kids can get all the way up to 0.5 eye times. Our PEEP, we always set just to make sure oxygenation, looking at our x-rays, 8 to 9 ribs expanded. Even with bubbles and vents, we make their OG tubes in, ventilating, everything like that.
What is your flow trigger set at?
Our flow trigger, 0.3.
Always.
Pretty much always. So the flow trigger, it only triggers less than what the PEEP is set at. So if you set it at too high, the babies can't get the breath. So the higher the flow trigger, the harder it is for the baby to get the breath. These ones automatically come at 5, but I did look it up, and that 0.5 flow trigger is made for like term kids, like bigger than term kids.
Yeah.
So 0.3 works really great on neos, little bitty 34 and less, 36 and less.
I thought when you hit the suction, it was supposed to increase the O2. Does it not increase?
It does. It increases the O2 and the alarm silence. So that's also the other thing. When you hit this increase O2 button, even if your alarm is set here, it just does increase the FiO2. Unlike the G5,
Because last time,
it doesn't
I thought it always
say.
showed it to you.
This one, I don't know, it doesn't say. The G5 will go up with that
Oh, okay. So
yellow,
this one
that
you
orange.
Can't see what,
This one you
can't see what
don't.
it's going to be.
But that's why every time I set up the vent, I do go to screens, utility, make sure that is set, not at 0. It is set. These automatically go to 20% increase
For suction.
for suction and increase O2.
So both of them go up to 20.
Both
One
of them
doesn't
go up
do
to
more than
20.
the other.
Yep, I set
They're
them both
both
up
for-
to go to 20.
They're both for 2 minutes.
Both for 2 minutes.
So it doesn't really matter which one.
It doesn't, it's just when you hit that suction button, when you are suctioning, it gives them more flow, and so their PEEP doesn't decrease when you are
Okay.
suctioning. But no, the increased FiO2 and the suction, they both go up for 2 minutes at 20%.
How did you get out of the standby?
Yeah, absolutely. So to get into standby, it's screens and then this furthest button on there. It's just standby and you have to confirm. When you get out of standby, you just hit resume right there. This vent also doesn't trigger off of patient breath, so you have to hit resume. 840s, 980s, they do trigger off of patient breath, so just always hit resume when you are getting them. Okay. Also, so we never want our babies to be extubated or anything like that. When you are seeing the vent alarming, it's kind of giving you a really low pressure for your alarm. Always auscultate, make sure you're listening, make sure there's no leak. Is the leak really high? Can the baby's mouth be closed? Anything like that. Super low leak is always pretty much a leak or extubation, and your high peak pressures are occlusion. Most of the time it could be secretions. I've seen an alarm really high with a pneumo, anything like that. So if the baby's coughing, gagging, actively moving, and you see this peak pressure increase, maybe that's something you guys can quickly fix. Try suctioning, try repositioning a little bit, see if that changes it. If it keeps alarming high peak pressure, even after your guys' quick interventions, absolutely call the RT. That could be something like compliance issue, an occlusion in the tube, or something that would probably require a couple more hands for us to look at. The PEEP alarm, I set pretty low on this, but that's just saying that there isn't enough flow going into that baby's lungs, but that's why I put on the AAC and that tube compensation, so that way you guys should never see a loss of PEEP alarm. Any other questions about alarms that you guys might see? The high respiratory rate, we pretty much know what that is. If your baby doesn't look like they're actually breathing that fast, most of the time that's water trapped in the tubing that's triggering that, so just drain it out, make sure it's like that, and then we can also change that. That is when we can change that flow trigger to go up slightly higher. That way it's not just catching the water droplets and giving the baby breath off of that. Any other questions?
Thank you, Kayla.
Yeah, you're welcome.